29%. That was the percentage of patients readmitted to the hospital within 30 days that were discharged on intravenous antibiotics. This is over twice the rate of the rest of the hospital. And this is important. It's important because 1 in 1,000 people in the United States will require a course of intravenous antibiotics per year. Also, almost 2,000 patients at HUP and Presbyterian hospitals will be discharged from the hospital on intravenous antibiotics. This definitely improves the quality of life for patients, being able to complete a course of intravenous antibiotics at home, some of which may be as long as 6 weeks. There's a lot stacked against these patients. They're sick. They're being treated for severe infections like heart valve infections. They're going home on intravenous antibiotics, many of which are very toxic if not monitored appropriately. Finally, they're leaving a controlled environment in the hospital and entering a very decentralized healthcare delivery system. This is only a fraction of the places that our patients go after they leave the hospital. So when you look at this, you could argue that 29% is expected or even acceptable, but we can do better. Our goal was a simple concept: bring centralization to a decentralized system. Through this concept, the Infectious Disease Transition Service, or IDTS, was formed at both HUP and Presbyterian hospitals. IDTS is a multidisciplinary care coordination team that takes ownership over this process and makes sure that our patients get the care that they need and deserve, even if they're outside of our healthcare system. So through this service, we've been able to take that 29% and decrease it to 16%, which represents an over 40% reduction in 30-day readmissions. But we can do better. As of now, we follow only about 60% of patients that are discharged from the hospital on intravenous antibiotics. To tell you how we can do better, let me tell you the story of Jack. Jack has cirrhosis and had a recent bloodstream infection with Streptococcus mitis. He hasn't engaged in the healthcare system as well as his doctors would have liked. In fact, he hasn't gone to any of his prior follow-up appointments. Yet today, we expect him to go home on intravenous antibiotics for 4 weeks and infuse these himself. In order to address some of these issues, our goal was to create a care coordination command center, putting Jack at the center of care where he belongs, so that he can more easily interface and break down communication barriers with the experts that are following him, and that his care team can more easily coordinate with Jack as well. In this command center, what we hope to be able to accomplish is to be able to more easily identify patients leaving the hospital on intravenous antibiotics and be able to follow more of them. We also hope to decrease inefficiencies in the system by creating more real-time data feeds to be able to monitor them more easily. And also, we believe that an engaged patient is a happier and healthier patient, so we want to be able to engage them more in their care. Through this, we believe that we can continue to increase show rates in clinic, continue to drive down readmissions, and to decrease adverse events. We've been able to identify more patients. In fact, through electronic alerts, we've been able to identify 100% of patients at the time of discharge. This is compared to about 60% previously. We're also able to identify patients, over 20% of patients, over 24 hours prior to discharge so that we can engage with them better before discharge. We believe that by refining these alerts, we'll be able to identify patients sooner. As an added potential benefit, up to 14% of the patients that we were not following probably don't need intravenous antibiotics, and we'd be able to save the healthcare system these costs, as well as saving patients the risks of going home on intravenous antibiotics. We've also been able to improve team efficiency. Much of our team's time is spent tracking down labs from nursing facilities and home infusion companies. So we figured, why not just tap into the data feeds ourselves? So we've been able to get feeds from both Quest and LabCorp, which represent a majority of the patients that we're following outside of Penn. We believe that by automating the system better, we'll be able to save at least 10 hours per week in our team's time, which amounts to being able to follow at least 300 more patients per year. We've also been able to engage patients more in their health care. We did what we referred to as a Concierge Pilot, where we engaged patients through text messaging. Almost 70% requested some assistance, but a lot of this was very simple and could be handled by an automated system. But at the very least, we can integrate this into our command center and use it to triage requests for patients and better engage them in their care. In this pilot, we had close to 90% of appointments attended after discharge, and 0 of these patients were readmitted. So how did we help Jack specifically? Jack was identified by our alerts and engaged in care. He enrolled in our texting pilot, and through this, he was able to easily communicate with the experts taking care of him that his home infusion company had left his blood work behind. We were able to escalate this, get it to the proper location, run it, and actually determine that he needed an emergent blood transfusion, and were able to do that without admitting him to the hospital. So we figured that for every Jack we take care of, we save over $2,500 in post-discharge costs. Extrapolate to the over 1,000 patients that IDTS is following already. That amounts to over $2.7 million, but we can do better. By capturing all the patients that are discharged on intravenous antibiotics, we can save close to $4.5 million in healthcare costs, not to mention extending the services throughout the healthcare system to better take care of the patients that we're monitoring. So thank you for your time.